We're diving straight into one of the most intense and, frankly, confusing scenarios you can face in emergency medicine: a massive pulmonary embolism. This is one of those situations where your training, your instincts, they can actually lead you to make a fatal mistake.
So picture this. A patient gets rushed in. They can barely breathe, their hands and feet are cold, and that monitor is just screaming at you. The blood pressure is in the basement. Every fiber of your being, every textbook you've ever read, tells you to do one thing, right now.
You see shock, you give fluids. It's medicine 101. But what if in this one specific case, that bag of saline you're about to hang is actually poison? Yeah, that's the crazy paradox we're going to unpack today.
And that brings us right to our first huge medical trap, a lesson straight from our expert guide in this story, Dr. Unmesh. It's this idea that sometimes the most obvious answer is the most deadly one. Okay, check this out. It's all about framing the diagnosis. See, in your typical shock from something like sepsis or bleeding, the body is like a car with an empty gas tank. You got to fill it up with fluids. But our patient? They've got these bulging neck veins and their lungs sound clear. This isn't an empty tank. It's a blocked pump. This is obstructive shock. And trying to pour more fluid into a system that's already blocked is, well, it's a disaster.
And that's the million-dollar question, isn't it? It's exactly what the junior doctor in this story asked. How can the one thing we always reach for to save a life suddenly become the thing that could end it? The answer is all about the physics of the heart.
So let's get this straight. Obstructive shock means there is plenty of blood in the system. The volume is fine. The problem is a physical blockage. In this situation, a huge blood clot that's literally stopping the heart from doing its job. It is a plumbing problem, plain and simple, not a volume problem.
And this is how it goes wrong. It's called the death spiral. First, you've got the clot, the blockade. So the right side of the heart, the right ventricle, or RV, starts to swell up because it's pushing against the brick wall. Now, you add fluids. That stretches the RV out even more, like an overinflated balloon. It gets so big it actually shoves the wall between the heart's chambers over into the left ventricle, squishing it flat. And a squished LV can't fill up with blood, which means the blood pressure tanks even more. You're literally choking the heart from the inside.
And that mechanical failure, that's the septal shift. It's this terrifying chain reaction, and it all starts with one seemingly harmless bag of IV fluid.
So let's say you've navigated that first trap. You didn't give the fluids. But now a lab result pops up on your screen. And it seems to confirm everything. But in reality, it's another trap waiting to be sprung.
The D-dimer test comes back. The number is 600. Now, in most hospitals, anything over 500 is a red flag for a blood clot. So that's it, right? Confirmed pulmonary embolism? Case closed. Well, not so fast.
This is where that next level of clinical wisdom comes in. There's something called the age-adjusted rule.